Hello friends, so today we are going to study the cancer of the pancreas, and in this there is one cancer that is less common, IPMN, intraductal papillary mucinous neoplasm. So intraductal papillary mucinous neoplasm, IPMN, they are mucin producing cystic neoplasm that arise and therefore communicate with the pancreatic ductal system. Okay, so arise from the pancreatic ductal system, and this neoplasm can progress over time from low to intermediate or to high grade dysplasia followed by an invasive carcinoma similar to pancreatic intraepithelial lesions. So benign IPMN, so there are benign IPMN, they have according to their papillary appearance on microscopy with each associated with particular mucin expression pattern, like there is intestinal type, and there is gastric type, and then there is pancreaticobiliary type, and intraductal oncocytic neoplasms. So clinically IPMN, they are classified as involving the branch duct or the main duct, and with some lesions having both of this, that is mixed type. IPMN are the most common pancreatic cystic neoplasm, and with an increased usage of high resolution cross-sectional imaging, and are believed to develop in 1 to 5% of the general population. So while all IPMNs harbor malignant potential, there is a wide range of malignant potential among encountered cysts. Main duct IPMN harbor associated with a 40% lifetime, for 40% of the time, and a pancreatectomy is generally recommended for patients with main duct IPMN who are medically appropriate. Small branch IPMN without any concerning radiological features have a risk of cancer less than 5%, and there have been a considerable effort to try and determine which IPMN harbor invasive cancer or are in higher risk of malignant transformation and warrant resection. So the original Sendai guidelines, they are now revised, that is Fukudo guidelines. Fukudo guidelines recommend resection of the cyst in a surgically or medically appropriate patients who have high risk which stigmata. High risk stigmata are jaundice, enhancing mural nodule of more than 5 mm, and main pancreatic duct diameter of more than 10 mm. And for those, so 3 features of Fukuda's revised guidelines recommended cyst for surgery, and in case of high risk features like high risk stigmata, jaundice. First is jaundice, second is enhancing mural nodule of more than equal to 5 mm, and main pancreatic duct of 10 mm. And for those without high risk stigmata, but there are worrisome features, and this worrisome features is pancreatitis, cyst is more than 3 centimeter, and then an enhancing mural nodule of less than 5 mm, enhancing thickened cyst wall, main duct 5 to 9 mm, change in caliber of the pancreatic duct with glandular atrophy, lymphadenopathy, CA19-9 elevated, cyst growth more than 5 mm in 2 years. EUS is recommended. So which are the worrisome features of IPMN? Worrisome features, first is pancreatitis, then cyst is more than 3 centimeter, then there is enhancing mural nodule of less than 5 mm, enhancing thickened cyst wall, main duct is 5 to 9 mm, change in caliber of the pancreatic duct with glandular atrophy, there is lymphadenopathy, there is elevated CA19-9, cyst growth is more than 5 mm in 2 years, and endoscopic ultrasound is recommended. So depending on the finding of the EUS, pancreatectomy, that is mural nodule of more than 5 mm, main duct involvement, suspicious positive malignant cytology, or radiographic endoscopic surveillance may be recommended. And the American Gastroenterological Association released their own set of cyst surveillance guidelines advocating for less frequent monitoring and they have been met with the controversy. And more recently, the European study group on cystic tumors of the pancreas, they released an evidence-based guidelines that call for conservative management of mucinous cystic neoplasm and IPMM of less than 4 centimeter. So European guidelines have showed the conservative management for the mucinous cysts which are an IPMM which are less than 40 mm in diameter without enhancing mural nodules. So surgery should be done in otherwise medically appropriate patient when the main duct IPMN when the main duct IPMN and there is main pancreatic duct diameter of 5.5 to 9.9 with the cyst diameter of more than 4 mm. So that then surgery should be considered. And the absolute indication for surgical management include jaundice, and there is enhancing mural nodule of more than 5 mm and main duct is more than 1 centimeter, who are otherwise fit for surgery. Then ECOG occurring is actively accruing patients to a randomized control trial examining how frequency of cysts and surveillance impacts outcomes. So invasive cancer associated with IPMM grouped into either tubular, conventional pancreatic duct adenocarcinoma or colloid subtype. And the former typically more aggressive. Tubular is more aggressive and develops from the pancreatic biliary IPMN, while latter, that is colloid subtype, usually develops from intestinal subtype. IPMN associated cancers, they have more favorable prognosis compared to conventional. This has been attributed to lower stage at diagnosis that results from incidental detection of the cystic neoplasm from increased utilization of the cross-sectional imaging when matched stage for stage. Two pancreatic cancer types are associated with a similar outcome. A multi-institutional analysis of IPMM with small foci of invasion less than 2 centimeter reported a recurrence risk of 24% with the majority being distal mets. So whole exome sequence of IPMM revealed roughly half of the number of the mutation, approximately 27 per tumor, and compared to pancreatic duct adenocarcinoma and high incidence of RNF43 mutation, tumor expression of E3 ubiquitin ligase activity and involved in protein degradation. KRAS genes, they occur in high frequency DNA based sequence of pancreatic cyst fluid. They show KRAS genes and high specific for IPMN. P53, PIK3, CA, P10 mutation, they associate with the advanced neoplasm and routine next generation sequencing of the pancreatic fluid. DNA has not been widely adopted in the clinical practice. So second is mucinous cystic neoplasm. They are typically large and they have a unilocular cyst lined by tall columnar epithelium, and benign mucinous cystic neoplasm, they are categorized similar to the IPMN from low to high grade dysplasia, and approximately 1/3 cases harbor invasive cancer. Additionally, RNF43 and KRAS mutation are frequently present like IPMN. Distinguishing features of mucinous cystic neoplasm from IPMN include female predominance with 90%, whereas IPMN affect males and females equally. So mucinous cystic neoplasm, they mainly affect female and in their 40s, and IPMN affect males and females equally. Left-sided, that is distal location within the pancreas. Ovarian stroma in mucinous, they are mostly in the tail of the pancreas, and they have a mucinous ovarian stroma underlying the epithelial component, and this pathognomonic is seen in affected male patients. Mucinous cystic neoplasm do not communicate with the main pancreatic duct, so there is low amylase level, while mutation in the KRAS is frequently seen in all mucinous neoplasm. And IPMN GNAS mutation have not been identified in the, so GNAS is specific for the IPMN, it is not seen in case of mucinous cystic neoplasm. And third is the solid pseudopapillary neoplasm, SPN. So these are as the name suggests, they are solid and cystic tumors. Eponymously refers to the Hamoudi or Franz tumor, and they typically occur in young females, so it is known as daughter tumor, and may arise throughout the gland. Histologically, they consist of non-cohesive polygonal cells that form solid masses but develop cystic component over time with a frequent intracystic hemorrhage. So tumors are considered low-grade malignancy with 10% risk of lymph node spread in the resected specimen, 95% of the lifetime recurrence-free survival rate after resection, and SPNs develop fewer than 5 somatic mutation per tumor. Virtually all SPNs harbor CTNNB1 beta-catenin mutation, and this molecular abnormality is believed to contribute to the poor cohesive between the cell appearance on microscopy. While wild-type beta-catenin interacts with the E-cadherin cell-to-cell junction.